Okay, everyone. Well, today we're going to be looking at an elbow ultrasound. So we have our lovely volunteer Omna here today, and we're going to be looking at the elbow. So I've got a little arm here with the elbow. So just like the shoulder and multiple other areas of the body in MSK, we divide the body part up into quadrants. So with the elbow, we've got 4 quadrants. We've got the anterior, lateral, medial, and posterior aspect of the elbow. So looking at the anterior aspect of the elbow, we've got our radial head sitting in here, and then we've got our radial fossa, then we've got our coronoid. With our coronoid fossa, we'll be looking at the cartilage overlying the distal aspect of the humerus. We'll be looking at the common extensor tendon as it attaches to the lateral epicondyle here. We'll be looking at the annular ligament that helps to stabilise the elbow. We'll be looking at the radial collateral ligament that sits just underneath the common extensor tendon. If we move posteriorly, we'll look at the triceps insertion onto the olecranon. We'll look at the olecranon fossa and the joint line back here for any increased fluid. If we look at the medial aspect of the elbow, we'll be looking at the common flexor tendon. We'll be looking at the lateral ulnar collateral ligament and 2 of its branches, the posterior bundle and the anterior bundle of that ligament. We'll also be looking at the median nerve anteriorly. We'll be looking at the long head biceps tendon anteriorly, and we'll be looking at the radial nerve. So let's get started. So more often than not, when you do an elbow ultrasound, the clinical indication will be query tennis elbow. So tennis elbow refers to the common extensor tendon of the elbow, so it's out here on the lateral aspect of the elbow. I'm using the 17 megahertz probe on a musculoskeletal superficial setting. Depending upon patient size, you might be using a 12 megahertz probe. As always, use the highest frequency probe that you can to get the penetration that you need. So with Omna's elbow here, the 17 megahertz probe works quite well. So I just place the probe on the lateral aspect. You can feel the bone underneath your finger, and so you just put the probe there, scan through, and there's the common extensor tendon attaching to that lateral epicondyle. So we'll just adjust our imaging parameters here a bit. So we've got way too much depth. Our focus is too far back, so we'll bring that up and narrow that down a little bit. So here's our common extensor tendon attaching to the lateral epicondyle. Here's that lateral joint line with the radial head. And we might just magnify that whole image up a bit so you guys can see it a bit better. So when we look at the common extensor tendon, it's like any other tendon. We're looking for these nice black and white lines, this nice fimbrial pattern. We're looking for the hypoechoic fascicles within the tendon, and we're looking for this echogenic endotenon that attaches or that wraps around those fascicles. And we can see here we've got nice normal tendon architecture. We look at the articular cartilage. So this area here is what is termed the enthesis organ. That's where we get a lot of problems. So we look to make sure we've got a nice hypoechoic cartilage, that the underlying cortical surface is nice and smooth, that there's no increased echogenicity in the cartilage, that there's no thinning of the cartilage. Now be aware that the common extensor tendon doesn't run from here all the way down to the cortical surface. No, the common extensor tendon takes up about half of the footprint of the lateral epicondyle. So the common extensor tendon only goes down to about here, where you get this little bump on the lateral epicondyle. Deep to the common extensor tendon, we have our radial collateral ligament, which is one of the important stabilizers, like I was saying, of the elbow joint. So the fibers of the radial collateral ligament and the common extensor tendon tend to blend in together, so it's very hard to differentiate them. We can see subtle differentiation here with Omna. We've got the superficial common extensor and then the deeper portion of the radial collateral, but really just know that this deeper portion is the radial collateral ligament. I move a little bit posteriorly, angle anteriorly, and here we can see the radial collateral ligament extending from that deep aspect of the lateral epicondyle onto the radial head. Now, you need to move the arm when you look at these things, because sometimes tears in these structures don't become apparent until you start moving things around. and then you can pump joint fluid out through the tear. It acts like a good contrast, so it shows up a nice little tear there. But in this case, it's all lovely and normal. Now, if we move a little bit posteriorly with our ultrasound probe, increase our gain a little, angle anteriorly, we can see this echogenic inverted triangle. This is what they call the plica, or the lateral, or the posterior lateral synovial fold. Always look at this. It should have this inverted sail-like appearance. If this plica has been damaged, it will swell, become hypoechoic, and if left untreated, can cause destructive erosion of the adjacent cortical surface. So make sure it looks like it does here. Nice echogenic inverted triangle. It looks like the meniscus in the knee, or the labrum in the shoulder, or the triangular fibrocartilage within the wrist joint. Now, if we continue moving a little bit more posterior with the ultrasound probe, over the top here, we have our lateral ulnar collateral ligament. It's a very fine structure. Tracking through here, I'll just decrease that gain. Might zoom it up even a little bit more. This is our lateral ulnar collateral ligament, and that's another important stabilizer in our elbow. If these ligaments tear, our elbow becomes unstable and we have chronic problems. So identify that ligament and follow it down. So once again, it's just a little bit more posterior. They're only fine movements. Okay, so it's always good to go and look at your anatomy textbook and just refresh yourself on the anatomy. So that's it sitting through there. Now, we'll go back to the common extensor tendon attachment and the radial head. Over the top of our radial head, we have the last of the three ligaments, the annular ligament. So I'm going to turn the probe through 90 degrees. Here's our radial head. Over the top of the radial head is the annular ligament. And so as Omna internally and externally rotates her hand, you can see that radial head sitting underneath that annular ligament, and everything's happy days. It's doing its job. We've got a nice hypoechoic articular cartilage. The annular ligament's intact. There's no fluid going through it, so that's fantastic. If you want, you can move a little bit more posterior on the elbow and follow that annular ligament down to the supinator crest in the ulna. So that's probably a good thing to do as well. And we can rotate that hand again. It just looks nice doing it. Okay, so we go back to our radial head, and there's a couple of joint spaces in the elbow you should look at. One of them is called the annular fossa. Funnily enough, there's our annular ligament, and sitting in here is our annular fossa. So this is really an extension of the elbow joint. So if you get an elbow joint effusion, increased fluid within the elbow joint, if it gets bad enough, it can track out and sit in here. So you just have a quick look through that, survey all the way through it, make sure it's okay. Oh, one other thing I should say about the common extensor tendon, it's a big tendon, so make sure you go all the way through the tendon when you're surveying it, and look in longitudinal and in transverse. Is our tendon here in transverse. Now, we'll get some of that gel and put it over onto the anterior aspect of the elbow. So if you can ask your patient just to extend their arm. Now, when you're scanning the elbow, there's lots of fine structures, so you need to be stable when you're scanning. So you can see how I'm resting my elbow on the table. It takes the weight off my shoulder because it gets tired, right? And also, I like to rest my fingers on the patient, right? And that way, it's actually a pretty comfortable scan to do. I like scanning elbows. They're nice to scan. So now we're sitting here looking at the anterior aspect. And what we've got here is the biceps brachitendon. So we've got our biceps muscle here. It's got two heads, a short head and a long head. They come down and they form the biceps brachitendon. The short head goes off to what we call the aponeurosis in the proximal forearm. It's a fan-like structure. The short head goes down, so you don't really see much going on there. The long head, however, does stay as a discrete tendon, but it dives really deep. It's hard to see. So how I find it is I find the tendon, sitting up in here, and I make sure that I angle my probe. Can you just hold that lovely? That way it stops the cord. Yeah, that's good. So there's our tendon here. Make sure you don't have an isotropy, so angle your probe so you're at right angles to the tendon fibres. And then what I tend to do is turn the probe through 90 degrees, so I'm longitudinal. Here's the tendon here. And then I move my probe, because the tendon, see how it dives quite deep? I move my probe to the medial aspect of the proximal forearm, adjust the depth a bit so I can see the cortical surfaces, bring my focus back, and then I angle laterally, and hopefully I run into that long head of biceps brachii tendon. Right. So I'm not seeing it here, so let's go back and have another go at that. So there's the long head of the tendon, coming down here, turn through 90 degrees with your probe. So there's the tendon just here, turning, and then I want to angle medially. Here's the cortical surface here, so we're looking for tendon fibres as they come down and attach. Let's bring that focus back a little further, and here's the long head of biceps as it inserts onto the radius. So you have a bicipital radial bursa that normally you don't see sonographically. That can swell. If it does, you'll see this black halo around the tendon. You can tear this tendon, right? So in which case you wouldn't see the nice alternating white and black lines, the endotenon and the fascicles. So just survey through it and look at that. This is such a strongly anisotropic structure, not just because it's a tendon, but it's also its orientation. So if you examine it in transverse, you can easily overcall tears. So make sure if you think there's a tear that you can see it in both the longitudinal and the transverse plane. Now, if I keep the ultrasound probe in essentially the same plane, so like so, and I just angle the probe medially, hopefully we come into the median nerve. Let's try that. So there's the tendon again. Just angle slightly medial in the same plane, and we should see the median nerve coming into view. There it is. I'll just adjust my depth a little. Here is the median nerve tracking through here. Right, so most times compression of the median nerve is down in the region of the carpal tunnel in the wrist, but occasionally you can get compression up in here. So you just look at the nerve, make sure the contour is nice and smooth, and that you can't see any mass effect, like there might be a neurofibroma or a schwannoma growing in that nerve. So that looks lovely. Then, a couple of other things we look at on the anterior elbow is the articular cartilage of the distal humerus. You can see through here this nice hypoechoic line adjacent to the cortical surface. That's quite normal. When it becomes abnormal, it gets more echogenic and you get thinning, right? So these areas here that look a bit more echogenic, just be careful that you don't overcall those, because that's just related to the direction of your ultrasound beam to the articular cartilage. So make sure you're at right angles to it again. And then if I go longitudinal on that, and I go over to the radial side, so here's our radial head. So we've gone to the radial side. We're going to look at that radial fossa and the coronoid fossa in the elbow. So the radial fossa, is not as deep as the coronoid fossa. So here's our radial fossa, and then we move medially, and here's our much deeper coronoid fossa. So if somebody fractures their elbow, or if they've got an elbow joint effusion, this is where you can get fluid building up. If you get fluid building up, it displaces the overlying fat pad, which shows up on the x-ray as like a fat pad sign, the anterior fat pad. And it looks like a sail, like a hypoechoic or black sail on the X-ray. On ultrasound, you would just see this hypoechoic or anechoic collection, and this fat pad here, instead of it looking like an inverted triangle, it flattens off and is displaced anteriorly. So this is what a normal elbow should look like. And you can move the arm a little bit and see whether or not you can get fluid tracking into it. But that's all lovely. Great. Oh, sorry. There you go. So that is that, and the radial nerve. So we have our radial nerve that goes down to our thumb. Median nerve sits in the middle, goes into the carpal tunnel, and then we have our ulnar nerve, sort of tracks around the back of the elbow, goes down towards our little finger. So we've had a look at the median nerve. Now we're going to have a look at the radial nerve. The radial nerve's very small, all right? So it's hard to find. So the way I find it is I move up into the level of the distal humerus. So let's just change our imaging parameters a bit here. So we'll decrease our depth, bring our focus up a bit, increase our gain just a little. And what I look for is this white echogenic area, and that's where our radial nerve sits, right? Now, the radial nerve branches into two. We have our deep and superficial branch. The superficial branch goes through what we call the arcade of Froude, or Fruge, right? And that's where you can get entrapment. So it's called the PIN, the posterior interosseous nerve, and that's a superficial branch of the radial nerve. So I'm just playing with the imaging parameters to make sure they're ideal. So I'll decrease my depth, I'm moving my focus up because I'm really focusing on this area here. Remember, these things are 0.5 millimeter big, right? So arm on the table, fingers on the patient, probes resting there, so your shoulder's not getting sore, and you can stay nice and still on things. So I'm moving down the arm, right, and then it's starting to branch into the deep and the superficial branch. And then you turn through 90 degrees on that. And here's the superficial branch of the posterior of the radial nerve as it travels through the heads of the supinator muscles. This is it here, right? That's beautiful, and this is what it should look like. So we'll put some calipers on that just so you can see it. This is the little nerve through here. Now it does vary in size as it travels through that arcade of Froude from about 1.2 to 1 millimeter. But essentially, what you're looking for is a nice smooth contour as it passes through. So this is where it gets trapped. That's that one. So now we'll go and have a look at the posterior aspect of the elbow. So I'm just going to lower the table down a little bit here because otherwise Omna's shoulder is going to dislocate. Alright, so that'd be lovely, thank you. Alright, so we have posterior aspect of our elbow, not our shoulder. So in the posterior aspect of your elbow, you're looking at the triceps muscle as it comes down and attaches to the olecranon. So 3 heads to your triceps muscle, they all tend to blur into one on the ultrasound. So really what we're looking at, this is the tendon here, cortical surface once again. As always, is it smooth? Is there pitting? The articular cartilage adjacent to the cortical surface, is it nice and hypoechoic? Now remember, the triceps muscle attachment goes round the olecranon and sort of attaches in here. So as a result, you need to use a bit more gel, and you need to follow that triceps around. Right, so I've got this little gel sort of mound here. You can see that triceps attachment, and I'm just making sure that I've seen it all the way onto the insertion, looking for spurring, sort of any abnormality of the cortical surface. It should be nice and smooth. Now, the olecranon bursa. So the olecranon bursa is a bursa that sits over our elbow. So when you grab the skin here, that's the bursa in there, right? Normally you don't see it on ultrasound. If you bump it, if you have a penetrating injury or an infection, that bursa can swell up. They're very easy to compress, so when you look for those, make sure you do like we've done here, have a little mound of gel so your probe's not squashing the bursa, and this is where you'd see it, and they can get quite big. On the posterior aspect of the elbow, we also look at the posterior elbow joint. Oops. So here's the joint through here. So this is distal humerus, and there's olecranon there. And then there's the olecranon fossa. So if I bring the focus down, this is where the olecranon bone has to go when we straighten our arm. Otherwise, we couldn't straighten our arm. This is where we have our posterior fat pad. So we had the anterior fat pad and the coronoid fossa. Same deal here. If there's a fracture, joint effusion, you can get fluid tracking out of the joint, sitting in here and displacing that fat pad. So just like on the anterior aspect, we can move the arm a little bit. That's the other reason I like to scan the arm in this position, is A, it's not too bad for the patient, and B, it allows me to take the arm and just move it myself. I find if you allow patients to move it, generally it's okay, but sometimes they'll move too fast and you're trying to stay still on an area and it just gets impossible. So if you control the movement, you control the speed and you know what they're doing. So that's our posterior elbow. And then one last area is the medial elbow. So in the medial elbow, you start off with the ulnar nerve. So if anyone's hit their funny bone, they'll know the nerve that I'm talking about, because that's the nerve that you hit. So if we look on the medial side, we'll just adjust our imaging again. So we'll decrease our depth, bring our focus up, because we're looking at more superficial structures. This is our ulnar nerve sitting in here. Now, the ulnar nerve is like any other nerve. We describe it as a bunch of grapes or a honeycomb appearance. So you have the hypoechoic fascicles of the nerve surrounded by the epitenon. When it's at the level of the cubital tunnel, which is where we are now, that constant friction over the years as we flex and extend our arm, it's normal for the ulnar nerve to be a little bit more hypoechoic. So that's perfectly normal, right? What we're looking for is big swelling of the nerve, and we're also looking at the tissue around the nerve. When the nerve becomes irritated, the tissue around it becomes more echogenic and bright. So we look for that. So the other thing you want to see is whether or not this ulnar nerve subluxes or dislocates. So over the top of the ulnar nerve, we have Osborn's fascia or Osborn's ligament. That forms the roof of the cubital tunnel and it helps to hold the ulnar nerve in place. When we flex and extend the arm, that nerve should stay in that tunnel, as it does in Omna's case. So that's lovely. However, it can pop out, alright? So a dislocating ulnar nerve. Be aware though, it's really easy to slip off the tunnel and overcall dislocating ulnar nerves. Just in here, we have the fibres of the common flexor tendon. A dislocating ulnar nerve sits superficial to the fibres of the common flexor tendon, so look for that. So that's our ulnar nerve. We look in trans, assess it for stability, turn through 90 degrees, look at the contour of the nerve, making sure it's nice and smooth and there's no mass effects and no increased echogenicity in the tissue around it. Put your colour on, right? I should have said that earlier. Use your colour liberally in the elbow and with all musculoskeletal, looking for increased vascularity, and that's perfectly normal. That's a normal nerve. We're not seeing increased vascularity that you might get with neuritis. So if we look immediately deep to the ulnar nerve, we have the posterior bundle of the ulnar collateral ligament that sits through here. And then if I turn through 90 degrees, we can identify the common flexor tendon. The common flexor tendon is a shorter tendon than the common extensor tendon, so you only see a few fibres. But same as always, look at the cortical surface, look at the echogenicity of the tendon fibres, and that's lovely. Now, immediately deep to that common flexor tendon, we have our ulnar collateral ligament. So let's see if we can find that again. This is a very fine structure. And this is it sitting through here. You can see how it's adjacent to the joint line. And that's an elbow ultrasound. Thank you.